Hello, and thank you for checking out FirstcallID, How to Do an Infectious Diseases Consultation. My name is Paul Bunce, and I'm an ID physician. In this video, we'll be spending the next 10 to 15 minutes reviewing the key aspects of an ID consultation when we're asked to see a patient with a peri-prosthetic joint infection. If you haven't done so already, please check out our first session on how to do an ID consultation, which covers a lot of the basics regarding ID consultations in general, whereas this session focuses on patients with peri-prosthetic joint infections. And before we move forward, just a quick note that this content is intended for educational purposes only. Please consult current guidelines and use clinical judgment when applying it in your practice. Here are the key components to include in your assessment of a patient with a PJI. First, we want to clearly document their chronology of prior joint surgeries, when they were performed, what exactly was done, and what was the indication for surgery at the time. We want to understand their relevant comorbidities and current medications. Also, are they currently on antibiotics or were they recently taking antibiotics? Are they receiving immunosuppressant medications? And are they on anticoagulants or other medications that would be sensitive to interactions? We want to understand the details of the current presentation in terms of the symptom timeline, the details of the recently performed or planned surgery, and if there's any plans for future revisions down the road. In addition to our general assessment and assessing the affected joint, we'll examine for extra-articular signs of infection and inflammation. We'll review the general investigations, but also pay attention to markers of inflammation, both the current and prior microbiology, especially of the affected joint, and reviewing the imaging. And from this information, we'll provide our summary and recommendations in which we define the syndrome and the current state. And also, we'll consider at this point early on whether oral antibiotics could be introduced early in their course. So taking a step back, when should we be suspicious or concerned about a PJI? A colleague of mine who's an orthopedic surgeon used to say whenever he saw a patient who had an unhappy prosthetic joint, he would be concerned and begin evaluating for a PJI. Some clues that we can pay attention to. So pain in the prosthetic joint, especially if it's new, persistent, or worsening. If there's swelling or erythema, even in the absence of warmth. If a patient's developed a sinus tract or wound breakdown, that's highly suspicious for infection. And one of the things I often tell patients is that bacteria like to make fluid. The fluid likes to find a place to go, and often that's the path of least resistance, which is usually along the surgical incision site. Patients may develop a fever or other elevated inflammatory markers. They may have systemic signs of infection where there's no other focus that's identifiable. And on imaging, sometimes you'll actually see loosening of the joint, which could be concerning for infection. Some cases will have a heightened suspicion for infection. If a patient has a recent bacteremia and there's concern about hematogenous seeding, or a patient who's had prior PJI or complicated surgical course, they'd be just at higher risk of developing PJI in the future. I will say about the point about bacteremia, the majority of PJIs that develop are not a result of a later bacteremia seeding the joint, but more commonly bacteria that are find their way into the joint at the time of the joint implantation surgery. And then they just take time to grow and become clinically apparent, which can be days or weeks or even years after the surgery. Often it's hard to know whether the infection arose due to a bacteremia or as a perioperative contamination. And it doesn't often have a big impact on our treatment plans, but it is important to at least be considerate of. So back to the components of our assessment. So we want a clear chronology of the prior surgeries. So you sort of itemize your list of prior surgeries of the affected joint, including the nature of surgery. So what was replaced, implanted, or what was left in place? What was the indication for surgery? Was it because of pain, loosening, mechanical factors, or concern for infection? If there was infection, was it possible infection or confirmed infection? And how were they managed from an antibiotic perspective? Did they receive antibiotics at all? And what was the duration and route of administration? With respect to comorbidities, we do want to pay attention to whether they've recently received antibiotics or are receiving antibiotics, because some patients will present and they're already on suppressive antibiotics up until the time of surgery, or maybe held for a few days or so prior to surgery. And that's important because that can dampen the growth of the intraoperative cultures. I'll say that it's unclear how far in advance of a surgery antibiotics need to be held to optimize the growth intraoperatively. So If you hold antibiotics for 3 days or a week prior to surgery, is that enough time to allow the bacteria, if they're present, to grow in the lab? And it's not entirely clear. We'll pay attention also, is the patient, does it have any underlying immunocompromising conditions or immunosuppressants, which may affect how we manage the patient and our comfort with shorter versus longer course antibiotic therapies. And also paying attention to other medications like anticoagulants or things that would be sensitive to interactions. We'll also want to clarify the details of their current presentation. So how long after their last surgery did they develop symptoms that were concerning for infection? I'll often say, when did you start to worry, or your surgeon, when did someone start to worry that there was infection? Was it right after your last surgery, or did it just happen months or years after that last surgery? Also, how long have you had the symptoms before you're presenting now? Some people have pain or concern for infection for days or weeks or months prior to the surgery. In other situations, they'll be fine, and all of a sudden, with 1 day history of an acutely inflamed, swollen joint. If they've had surgery already, we're often consulted sort of 1 day postoperatively or even postoperative day 0. So what was actually done in the surgery? What was exchanged and what was retained? Okay. And also, is there planned further revision down the road? And sometimes it's not clear. There can be a patient who was planned for a single stage revision, and that's supposed to be the last surgery. Sometimes they'll plan for a 2-stage revision where they'll do 2 complete exchanges separated by several months. And sometimes it's kind of an in-between where they'll do the exchange and say, let's just see how it goes. And if we need to do a second revision, we will. But if this works out well, we might just leave that one in. When we examine the patient, in addition to our general examination, we'll focus on the affected joint within limitations. If it's in a brace and it's dressed, I might simply follow up on what the orthopedic surgeons, what their assessment of the wound is, but also look systemically and look for any extra-articular manifestations of infection or inflammation. And the one point here is that not all PJIs are really PJIs. So patients can develop other causes for an inflamed joint in a prosthetic joint. And I've seen seronegative and seropositive arthritis developed in a joint that's already had surgery and has a prosthetic in place. I've also seen crystal-induced arthritis in patients who have a prosthetic joint. So those are things to consider. We might still treat them as if there's potential infection, but it's good to keep those other possibilities in mind, especially if there's recurrently culture-negative quote infections. We'll review the investigations, routine blood work. We'll note markers of inflammation, most commonly the C-reactive protein, recognizing that there are several limitations of these sort of more general tests. We'll note the renal function, paying particular attention to current and prior microbiology, including gram stains and culture. And these are situations where we really will want to look back at all of the prior microbiology, especially of the affected joint, to see what's been there before. Also noting previous colonization. If they're MRSA colonized, we'll take that into account. Now, it is challenging sometimes to know how much to make our treatment decisions based on prior microbiology. We might impact our empiric therapy to cover what we've seen before. But say a patient had Staph aureus in the joint on a previous surgery, but on this occasion, it grows E. coli. Do we still need to cover what was there before, or can we just assume that it's been cleared? And I'd say that's a case-by-case decision. We'll also look at the imaging and read the reports of the affected joint just to understand, confirm, was all of the prosthetic material taken out and what was put in its place. From all of this, we'll provide our summary and recommendations. In this, we will define the syndrome and the patient's current state. We'll outline our preliminary management plan, likely to be modified as more information becomes available. Early on, we'll consider whether oral antibiotics might be an option and could be introduced early and maybe deferring a PICC line, or should they just proceed with the PICC line right away? And we'll communicate our suggested plan to the surgical team early on. So an example of this would be a 60-year-old male, status post complete revision of the left knee prosthesis due to late presenting PJI. Or cultures are pending, currently receiving cefazolin. An example plan would be, in this setting, I would anticipate a treatment course of 6 to 12 weeks of antibiotics, treatment duration and route of administration to be determined based on the organism, susceptibilities, and the clinical course. Regarding the empiric antibiotic therapy, I will usually leave patients on what they've been started on by the referring team, as long as it's safe and relatively adequate. I don't love changing antibiotics at this phase if it's not necessary, because in 1 to 2 days, I'm likely going to change it anyways, so I'd rather just leave it alone. Also, as a courtesy to the referring team, sort of showing them they chose something that was reasonable rather than making a point to change it just to change it again in 2 days. Also, at this phase, when I'm seeing the patient, I will consider whether there's a role for rifampin and just look into the possibility for interactions and just sort of thinking, is that an option? And again, early on, as I'm seeing the patient, I will just think, is there a need to request additional susceptibilities once microbiology becomes available? And this might not be something that you can address at the initial consultation, but it's important when you're seeing these patients in the acute phase. Later on in their course, even if you've chosen something that's very reasonable, they might develop side effects or intolerance where you need to switch agents. And so it's important to recognize early on that this might be the case and speak to your microbiology lab and often request additional susceptibilities for alternative agents that you might need to use. Also at this phase, I'll often float an email to the surgeon directly where I'll say, this is my assessment, this is my proposed plan, let me know what you think. And this way I can make sure I'm clear on what was actually done in the surgery. Was there any prosthetic material left in place, or was it a full revision, so that make sure we're on the same page. Also, sometimes the surgeon might have a preference to use or avoid certain antimicrobials. And that way we're talking about this up front and getting it cleared up so that we're not sort of figured out at the last minute. So here again are the key components or key points of our evaluation of a patient with a PJI. And as I leave this slide up for your review, I just want to highlight a few broader reflections. The first is seeing patients with PJI offers an opportunity for collaboration between orthopedic surgeons and ID physicians, both clinically and academically. The second is that the communication really pays off. So these emails and talking to surgeons directly, it builds trust, it reduces misunderstandings, and it tends to foster a mutual respect between the two teams. And finally, I really try to be consistent. So every case is unique and every case is different, but the surgical team and the team caring for the patient, including the pharmacist, if they can't anticipate how I'm going to approach the therapy, things just kind of get clunky. It can slow down the process and it can give the impression that you as the clinician are uncertain, even if you're just trying to be thoughtful. And so that consistency helps them anticipate what the next steps are going to be. And so it helps everyone involved, builds confidence and builds trust in your recommendations. I'll leave you with two references to reviewed articles or resources on the topic. The first is a New England Journal review article, Peri-Prosthetic joint infection. Excellent, comprehensive, worth reading as a summary of the major issues related to PJI. The second is a podcast from the Farewell podcast series called Truth or Dare, where they review a number of different scenarios of patients with peri-prosthetic joint infections and the surgical management and how our antibiotic management is influenced by what is done surgically. And this episode also highlights a lot of the uncertainty and some of the issues that we're hoping for more evidence to guide us in the future, but a really excellent review, especially if you're new to this topic, to summarize a lot of the key issues. So highly recommended. And so that's all for now. I'm Dr. Paul Bunce, and I want to thank you again for watching. Please share any feedback you have about the session or about FirstcallID as a whole. Check out our website, firstcallid.ca. We also have an associated podcast called The Host Response. It's on all the major podcast feeds. And if you like what we're doing, share us, tell a friend, let us know. And last of all, just take care out there. Thank you.